I would just like to add that some of the other studies that are being done to try to get at this issue of XMRV transmissibility is looking at blood donation practices and what's called the look-back study. So you look back on the people who have donated blood and then the recipients of that blood and whether or not there's actually any transmission of the disease, CFS. Not necessarily the agent, so it's an indirect way of looking at transmissibility by kind of looking for the disease. I don't think I have an XMRV question. So I'm going to address this one. Is there still a move towards renaming CFS to ME? Not that I know of. Our hope is that, that we're going to find markers. And you don't want to necessarily rename a syndrome to another syndrome, because a syndrome is basically a complex set of ill-defined symptoms that have nothing that you can kind of pin down. So our hope is that we identify objective markers that can identify the specific subsets, because as you've heard, these are spectrum illnesses. So there's likely several markers that are going to define the subsets, and I think we can probably do away with the name of CFS. That's my hope anyway. Do away with the name of CFS completely.
I have an interesting question that it always comes up. Is there a list of experts in the treatment of fibro and CFS in Salt Lake City who are accepting new patients? And then any specializing in the treatment of adolescents? And the answer to that is there isn't a list that we publish. And there are a variety of reasons for that and a host of problems associated with doing that kind of activity. My recommendation is twofold for patients who are looking for a health care provider. Would be one, contact offer either through our email or phone. We can give you some advice on where to begin. I know Cindy Bateman is recognized as an expert in the Valley, and people are constantly seeking her and often frustrated that they can't get appointments. But what Cindy has done, and what others on the board, for example, Lee would also do, would be he would be happy to collaborate and work with your primary care providers to help guide them and help them. The more healthcare providers we have out there who understand treatments and protocols and what to do with these situations, the better for everyone. So, Cindy?
If you are a provider that would like to be on a referral list, you would like to see patients and you would willing to have your name, we're not going to publish a list. We're not going to post it on the internet, but we get dozens and dozens and dozens of calls from patients who can't find physicians. And I have to say we have a soft list. We do have a list that but we'd love to have your validation that you'd like to be on that list. We'd like to have a list of 30 people so that there's not, there's a broad geographic distribution and there's a way to spread patients out because they are time intensive.
One other thing is that this afternoon we have a patient conference. If the patients will come to the patient conferences, and there's a monthly offer thing, they can talk to other patients and find out who's been very good, and who's been helpful to them. And I think that's very useful as well. Yes.
I feel that my practitioner is really trying his best, and I've talked with practitioners, but is there a way to get more information? Is that what you're kind of, what I mean? Is there kind of offering it every time I go into, or is there a way for me to get
That's what this conference is today. As an organization, we way overextend ourselves to try to provide this kind of CME. We'd like to do more of it. We'd also like you to know that we have a rich database on our website of lectures and talks that have been given over the past 5 or 6 years, and there are many other web resources. And it's an effort. Thank you so much, all of you who've come here today, because we really feel like we need a bigger team, of medical providers of all types to begin to tackle this very common set of problems.
That sounds like snoring in the back, and that's appropriate to this question about sleep testing. My experience is that about a fifth or a fourth of patients with fibromyalgia, more in a referral setting, have sleep apnea. And unless you treat it, you have a hard time getting rid of their problems because the nervous system's on constant overdrive with sleep apnea. And the question has to do with, can sleep testing be done at home, or does it have to be in a more expensive lab? There are places here in the valley and developing nationwide where you can study it at home. It's not just the little oximeter, but it's with a little band around the chest. Very accurate, it turns out. Costs, $200 or $300 and done at home. And we do that a lot. And so keep that in mind, particularly if a person has daytime sleepiness, particularly if they also have hypertension or edema. You want to screen for sleep apnea, because if they have it and you don't treat it, you're going to have a hard time solving the problems. Yes?
Isn't it true that that shows whether or not there's apnea or hypopnea, but it doesn't necessarily give you a picture of the arc?
That's correct. The home test is not using an EEG, and it's nice to have that, but you're just screening essentially for sleep apnea with the home test, not all of the other parts. The restless legs and so on are not being tested. And a surprising number of people have restless legs, which may well be the dopamine issue that Dr. Wood was talking about. I'm talking about, 40% of fibro patients often have restless legs, which is also sort of a CNS sensitivity problem. Let's see.
Lee, if I might add just a little corollary, that your point about sleep architecture is well taken, because in the absence of an EEG to demonstrate that, you can have non-restorative fragmented sleep in the absence of sleep apnea, and without an EEG study, you wouldn't know that, and you really miss an opportunity. I had a young lady, she's 17 years old, and she was put on Xyrem in the absence of sleep apnea. We sleep studied her, and she's had a complete turnaround. And the other thing is that I think that a lot of people need to have multiple sleep latency testing. In the last, again, I've been in Seattle for a year, and we've picked up 3 new cases of narcolepsy that would have been completely undetected had they not been in a sleep lab. So 3% of a population of 200 plus people is pretty impressive.
Keep in mind that that when you do this MSLT test, this is done after the nighttime sleep test. You do it during the daytime after their sleep test. And the people you would do it in is people who have sudden onset of sleepiness in the daytime. Or they may have, when they go to sleep, they have hallucinations when they first go to sleep. It's like dreaming as you're going into sleep. Then you might want to do this MSLT test in addition to the polysomnogram. One other question that I have, a different direction, unless anybody else want to comment on this?
I just wanted to add my 2 bits about sleep. That's one of my table legs. You just have to come back to sleep. And I think unless you can take a very careful sleep history and hit it right on the nose with your first interventions, almost every patient that falls in this category and really, I think, needs to have polysomnography. That's just my opinion.
Maybe we ought to just comment on sleep because it's one of those key features. The usual sleeping pills, we ought to maybe comment on. Benzodiazepine sleeping pills suppress deep sleep. Restoril and some of the older ones. The newer benzo-like agents like Ambien and Lunesta do not suppress deep sleep, but there's not a lot of good data that they restore it in people who lack it. And in a couple of studies of those benzoagonists like Ambien, Lunesta, in fibro, the sleep was improved subjectively, but the pain was not. So the agents that, like, for example, the Xyrem or another host of things that improve deep sleep seem to work better for the pain. Do you want to comment on that? Yes.
I'm sorry, pregabalin has been shown to improve stage 4 sleep. So I was saying, when you sort of are making your prescribing decisions, that's certainly one that should be kept in mind if sleep disturbance is a big issue. Obviously, I've had enough patients tell me that they've gained weight that I'm a little gun-shy about riding, that I really consider the BMI when I do that.
Here's another interesting connection, if I may extrapolate. You saw in the genetic studies with CFS, and this is also true in fibro, there's a subset that have problems with the serotonin 2A receptor. When the serotonin 2A receptor is over-responsive, you get lack of deep sleep, smooth muscle spasm, migraine headaches, more anxiety. And drugs that block 5-HT2A restore deep sleep. What are they? Trazodone is one that blocks 5-HT2. And there is one study of trazodone alone in fibro that was positive for outcomes. In a subset of people who have bipolar disorder, now this is a subset, but that's often a 5-HT2A issue. That's why you use atypical neuroleptics in bipolar that block 5-HT2. And those atypical, so we're talking about things like Zyprexa and Seroquel and so on, they restore deep sleep by blocking the 5-HT2A. So in general, those are a couple of categories of things that restore deep sleep. Incidentally, this bipolar issue as a subset, it's about a sixth of people with fibromyalgia have a bipolar spectrum mechanism, which is a lot higher than you go out in the population at large. You just have to keep that in mind. You may not want to start with one of the antidepressant-like drugs in that subset. Yes?
While you're on that, doesn't low dose Abilify have some unique dopamine activity?
Do you want to?
I'm a big fan of aripiprazole, Abilify. I use it liberally in comorbid affective, bipolar spectrum disorder. It's my go-to. It's also good for depression. I think most of the studies have looked at it as an add-on, but again, looking at biological variability within a label like depression, I mean, the DSM-4, when it's reprinted, will have subsets of depression made official. And so atypical depression and the bipolar spectrum, I think, are very responsive to Abilify. Abilify is interesting. It is just a dopamine stabilizer. So it takes the dopamine tone and locks it, whereas an old-fashioned neuroleptic would block it, and an agonist or an amphetamine or selegiline would promote it. Aripiprazole locks it, and I think it's very helpful for that way. There are some case reports of getting manic switch with it. When it first came out, I think people were being overly aggressive with it. 2, 4, 5 milligrams, I don't go over that.
There is one other question regarding antidepressants, how to deal with the stigma of using an antidepressant for these pain conditions. It's kind of an education issue. The studies using things like Cymbalta and Savella and tricyclics in fibromyalgia, they usually exclude anybody with depression. So that data you saw are in non-depressed fibromyalgia patients. We call them antidepressants, these SNRIs, because they were first studied in depression. But the fact is, depression is just one piece of that abnormality of those serotonin, norepinephrine. Lots of other medical problems occur with depression there or not. And so it's an education issue, I think.